So, good evening, everyone, and thank you for joining us for our sixth session, actually, of Legendo. We started in January and with really good positive feedbacks. Like the previous times, also this time, we're going to be joined by two great lecturers. Today we have Whitney Ross with us and Marina Kovaskov, and their papers are really, really great. We're really interested, so I'm looking forward to hearing their presentations. With us, there are the other members of the Legendo team. So we have Mikey Adamczyk, who's a consultant gynecologist obstetrics at St. Peter Hospital and the Lister Hospital. Shane Casali, that is a consultant at the Lister Hospital. We have Kai Flesher, currently working in Royal Surrey, and he's going to be the next fellow at the Lister Hospital with Mr. Casali. We have the current fellow, that is Avril Baci. And we have Jamie, who was a previous fellow of Mr. Casali, but is currently between Scotland and Germany. So before starting with the papers, I would like also to introduce like these two really great projects. So for anyone interested in surgeries, we have a series of light surgeries, and the second one is going to be the Saturday, 17th of June, where we're going to focus on electrolysis, energy use, suspension techniques. So please join us on Saturday, the 17th, for live surgery. Second project that is going to be the endometriosis bootcamp. Do you want to say anything, Mike, about the bootcamp?
Yes, I can. So it's a great opportunity for anyone that loves skiing and wants to learn more about endometriosis. It's organized by Shaheen Kazali and Mohammed Mabrouk. It takes place at the beginning of next year in a lovely French Alps, and we invite anyone that is interested in attending it to please join us. And if you have any questions, you can either contact myself or one of the team members from Legendo, or look at their website that is showing on the flyer.
Thank you so much, Mikey. I think, like, without further ado, like, we can probably start with our first three papers. They're going to be presented by Avril and Jamie today. So what do you have for us, Avril?
So it's actually me that's starting. Can you hear me okay?
Yeah. Okay. Go, Jamie.
So the first paper I was quite excited about, I've always been interested in with scanning, is a prospective international pilot study that's been brought about by the IDEA group. You might remember Professor Condis in Australia started this in 2017 because he's basically trying to formalize and standardize how scanning is done in order to get a comparable detection rate of endometriosis for MRI. So I'll show you a bit more about this. So they took 273 consecutive patients, and they all had TVS, laparoscopic and histological data, which are compared. What's important is each center had a particular surgeon, a particular sonographer, and they had almost full histology for all the patients. The operation had to be performed within 12 months, but with these ladies, they were performed within 3. This poll has now come up, which I need to get rid of because I can't move the slide now. Hold on one sec. That's fine. So the way they actually do the IDEA scan is as follows. You do a standardized scan and see if there's anything obvious. You then do soft markers. Is anything tender? Can you move the ovaries? You then do an assessment of the patch Douglas using real-time ultrasound and sliding sign. And then you assess for DIE nodules in the anterior and posterior compartments. Not going to go into this too much, but the paper's got a lovely graphic here of what you should be looking for. And when you actually look at the data itself, they found versus the Cochrane review, which had been done back in 2016, there was 88% accuracy, which is is comparable to 92% in MRI. It was actually very high. Sensitivity was good, but specificity was lower. And this accuracy was based on the algorithm you can see there. The only reason I'm flashing this up is they literally looked in every compartment. They compared everything between the surgeon, the TVS, and the histology that came out in different locations. There were 12 tables. And the pros of this study, as we said before, there was a steering group of experts. Most patients underwent complete excision. And it's the first big study to actually use 2 reference groups. So this was the transvaginal scan versus histology and versus what the surgeon could see. And they tried to homogenize the data where possible. The cons with this is some surgeons elected to ablate, so you didn't get all the histology. And if you had smaller endometrioma, you might not see them, or they might just be drained. The surgeons weren't blinded, so they knew what they were going into. Overall, this is potentially more accurate than surgical visualization. Plus, this would be quicker for diagnosis than an MRI. It's good for looking in the pouch of Douglas, the bowel, the bladder, and looking for endometrioma, but less so for retrovaginal disease and at the uterine torus. There you go.
Thank you, Jamie. Yeah, it's actually impressive. Like, I think it's very operator dependent. This is the only problem with the ultrasound. For example, in my hands, it's not the best tool. I'm not gonna lie to you, but some people are incredibly skilled with the ultrasound scan, and they can see anything. Remember, we went to the guy in Italy, and I think it was Dr. Di Giovanni that performed the transvaginal ultrasound scan before Malzoni's procedure. It was impressive how she could even delineate the rectovaginal nodule and follow the nodule.
That is quite impressive, yes.
So the Jamie spool is back. Oh, it's gone as well now. Okay.
Yep.
So the question was like, does your clinic follow formalized scanning protocol for endometriosis, either with transvaginal ultrasound scan or MRI? So 58% of people said yes. 42% no, so pretty much 50-50. I don't think like in St. Peter we have a formalized protocol for endometriosis without transvaginal scan. Yeah, with MRI we do, but we don't have any formal sonographer specialized in ultrasound scan. Would be really nice to have it actually.
Yes, but we also rely quite a lot on MRI scans for patients.
I spoke to our favoured radiologists here in Wishaw in the Central Belt in Scotland, and they don't have a formalised system. But since seeing this paper, they're actually going to have a look at it.
And by the way, if anyone has any question about the papers, want to make any comment, please write it on the chat, and we're going to pick it up. What do you have for us, Avril?
Okay, so my next paper is a paper by a team from the reproductive unit in McGill University in Canada, and they're looking at the effects of age and endometriosis on ovarian reserve in women with infertility. Next slide, please, Jamie.
Get this to work. Hold on, it's not picking it up. There we go.
Okay, so basically this is a cross-sectional study. They had a study group, they had a control group. And in the study group, it involves women with endometriosis. And they diagnose women with endometriosis based on their ultrasound scan, or if they had laparoscopic or histological confirmation. Next slide, please. Yes, and these are the results. So 585 people in the control group, 71 in the study group. And they found that the women with endometriosis had a lower median AMH and antral follicle count, and this was statistically significant. Next slide. They then divided these women into women aged less than 35 years old and women aged more than 35 or more. And what they found was for women less than 35 years old, only AFC there was a significant difference. But then for women who are over the age of 35, AMH and AFC were significantly lower. Yeah.
Sorry about that.
Next one. Yeah, that's fine. Just click play and then go to the next one.
I'm just having difficulty getting rid of this poll on my screen all the time. My apologies. There we go.
Yeah, just go to the next one, please. Yeah, okay. And then under women with endometriosis, they looked at women with endometriomas and no endometrioma. And what they found was there was an inverse relationship between AFC and the presence of endometrioma. But when I looked into these numbers deeper, those without endometrioma is such a small number, only 8. But those with endometrioma is just 53. And another limitation of this study is they didn't mention the size of the endometrioma as well. They tried to see if there was any difference in terms of the age. Again, there was no difference, but again, the numbers were very small. Only 2 patients aged less than 35 and no endometrioma. Only 15 patients more than 35 years old and no endometrioma. They also wanted to look at the effect of ovarian surgery on either the AMH or the AFC. And again, this was not associated with any significant decrease in the ovarian reserve markers. So in conclusion for this study, endometriosis does have a detrimental effect on ovarian reserve, and this is enhanced by age. And this is actually the first study which also looked at both endometriosis and age on ovarian reserve at the same time. And that's me. Let's see what the poll results are. Yeah.
Yeah, so 61% of people don't routinely consult patients for elective egg freezing. And I think it very much depends on the age, on how many kids the patient have, and on the starting AMH as well, and the size of endometrioma.
Yeah, so a lot of limitations in this study. No size of endometrioma, no live birth rates, but yeah.
And the numbers are like no high numbers. I mean, no endometriomas, only 8 patients. But yeah, it's interesting. Thank you, Aurel. What do you have for us, Jamie, next?
So next, if I can get this to work, there we go. This was a systematic review and meta-analysis of a subject that was actually alluded to in the ESHRE guidance back in 2022, I think it's about page 110. There's areas of obstetric sequelae from endometriosis. So they originally had 117 papers, reduced down to 19. And basically each paper was adjusted for design quality, risk of bias, and you had to include the following. So you had to have endo present versus a control group. You had to have the incidence of placenta previa and PPH during section. Also the surgical outcomes of section compared with women, between women with and without endo, and also the vaginal versus cesarean section delivery outcomes of women with endometriosis. Essentially, these 2 slides, they're looking at the meta-analyses of PPH and placenta previa, and with the PPH, the odds risk crosses 1, so wasn't felt to be significantly linked, but certainly on the placenta previa, when you're doing the meta-analysis, you can see the diamonds there, they're well above 1. And if you then look at the histologically confirmed endometriosis, so they went further into the sub-details, they looked at papers that specifically went into the histology, you have the same pattern again. They're not sure whether it's directly linked to PPH, but they certainly are with placenta previa. This is actually has an error at the top saying it's for PPH, it's actually for placenta previa, and the assumption is that has been made that those with endometriosis are more likely to require assisted reproductive techniques. But again, you've got this increase in placenta previa. What I liked about the paper is they did a huge amount of work on trying to control for all the bias that they could see. They used the EGGER test, which is to see whether there's publication bias, the randomized data bias, and also random effects analysis. Also, most of the studies are moderate quality rather than low. So remember, with this paper, we're trying to see why it's a good systematic review. Also, when they've tried to do this beforehand, they've not actually looked at directly the sort of injuries that you can get at cesarean section when you have placenta previa. And I thought this was a rather large number of patients, 66,000 from 3 million. I mean, that's a lot of data there. Problems here is that some of the papers themselves might have inherent bias when they were designed, so you can't always confound for that. And they didn't all have complete obstetric data. We also noticed there was some heterogeneity with primates, where they'd had incomplete excision versus complete excision of endometriosis disease. So this might actually confound some of the data coming through. So the takeaway points, it confirms what's been looked at before. You have this odds risk of 3.6 to 4.2, which is huge if you think about it for placenta previa. And if you have ladies who've got endometriosis, and I've certainly found this when we open people up for cesarean sections and find nodules and so on, there is this high risk of hysterectomy, for example, bladder injury, extended stay in hospital. What they're saying for research is, although there's a correlation between endo and placenta previa, we need to actually find this in a more direct fashion rather than associated surgical outcomes. So that's that paper.
Thank you so much, Jamie. It's very interesting. And actually, last year on the obstetric and gynecology, on the TOG, they published a really interesting paper that showed the association between endometriosis and pregnancy in general. And I invite everyone to go and have a look at it, because it also focuses on the pathophysiology, on how endometriosis can influence pregnancy. For example, how endometriosis increases the risk for preterm deliveries. And I think we're probably gonna invite also the authors, because it's very interesting. I wonder if in the future we are gonna have some specific antenatal pathways with endometriosis, actually.
That was an interesting paper, and I remember it. There was another
Yeah.
couple of good papers on adenomyosis and pregnancy and outcomes, looking at IUGR babies, etc. Jamie, you do, I guess you still do antenatal clinics. Do you, knowing this information, do you speak to patients differently now for patients that have previously were known to have adenomyosis or endometriosis? Do you counsel them just briefly?
Certainly with the adenomyosis, we need a link with there was this question with PPH. Now that I've actually read this analysis, that's what I will actually be doing. Yeah, going forward.
Good.
Excellent. So I'm going to introduce our first speaker for today. So thank you so much for joining us, Professor Whitney Ross. She works in the Division of Minimally Invasive Gynecology Surgery in the Department of Obstetrics and Gynecology in Washington University in St. Louis. And I read this paper a few months ago, and I was one of the consultants in Ashford and St. Peter that showed me this paper, Mr. Vasilis Minas, and I really loved it. So I was really happy to invite Professor Ross to the Legendo, and I'm really looking forward to hear your presentation. So she's going to focus on appendix and endometriosis.
Wonderful. Thank you all so much for inviting me, and I'm very excited to talk about appendectomy and endometriosis. It's one of my favorite things. Let's see. Okay. We had, in terms of the authors, these are disclosures, none are relevant to the topic. I did want to give credit that all of this study was conducted at Penn State Health during my fellowship. So in terms of background, endometriosis affects 10 to 15% of people of reproductive age. Appendiceal endometriosis has been reported with a prevalence of 0.8% to 39%, depending on which study population you look at. Coincidental appendectomy has been advocated in people with endo as it debulks endometriosis and theoretically decreases right lower quadrant pain, need for imaging for people presenting with acute pain, and the need for reoperation, although we don't have any long-term outcome or quality of life data. We also don't have any guidelines regarding coincidental appendectomy and the surgical management of pelvic pain or endometriosis. So the objectives of this study was to evaluate the role of coincidental appendectomy in the surgical excision of endometriosis. And then the secondary objectives were to look at interim postoperative complications. So this was a retrospective study of consecutive coincidental appendectomies that occurred between 2013 and 2019. The cases were identified prospectively through a surgical database. Each chart was then reviewed at least twice for data control. And then we conducted a variety of statistical tests, like 2-sample t-tests for continuous and chi-square for categorical, logistic regression, and multivariable logistic models to do predictive probabilities. In terms of results, we had 609 patients who underwent coincidental appendectomies during this time period. All were performed at time for primary gynecologic surgery, either for hysterectomy, most commonly operative laparoscopy for endoexcision, or laparoscopic tricholectomy. 16% of the patients had some kind of abnormal appendiceal pathology, most commonly endometriosis at 14.9%, but the other things that we identified were malignancy in 0.7%, polyps, and appendicitis, which are in concurrence with other international data. One of the things is kind of always reflecting on how to present this data is the endometriosis conundrum. We make our surgical decision based on what we know beforehand and the intraoperative findings, but then we don't have the gold standard until the pathology results. There's also significant discordance between visual inspection and what pathology will tell us for stage 1 and stage 2 to an extent. So in terms of thinking of the analyses, we presented it in 2 time points, 1 based on what we would know intraoperatively, and then 2 predictors looking back after knowing what the pathology showed. So this is our table 1 in terms of looking at differences by demographics. There was no difference by age in terms of if people had appendiceal endometriosis or not, no difference by BMI. There was a big difference based on indication for appendectomy, with those with chronic pelvic pain but no visualized endometriosis having the lowest rate at 2.4%, stage 1 to 2 endometriosis at 7%, and stage 3-4 at 35.2%. There's also significantly higher rate with those that had abnormal appendix appearance. And I'll say more about that in a minute. I think one of the things that was super interesting was that in looking then at what we found on pathology for people that had no endometriosis anywhere on any of our pathologic specimens, 6.1% of patients did have path-proven endometriosis in the appendix. So the appendix was the only site of endometriosis. In terms of looking at our adjusted analysis, so there was a 22.2% odds ratio of having appendiceal endometriosis in people with stage 3 to 4 endometriosis. And then with abnormal appearance, 6.5. 26% with appendiceal endometriosis appeared abnormal. So looking at it, you say, oh, that doesn't look good. We need to take it out. So this gave abnormal appearance a positive predictive value of 47% and a negative predictive value of 88%. Then in terms of looking at the other things that were significantly associated, essentially endometriosis confirmed on pathology anywhere else with or without fibroids and adenomyosis were associated with endometriosis in the appendix. So then in terms of looking at, for planning the statistical analysis, we grouped things into endometriosis sites. Now, kind of knowing what we know with the AGL staging app, I would do it differently, but basically kind of grouped by anatomic location so that anything, if there was 1 or 4 biopsies over the bladder, that would all get considered one site. And kind of the ones that were important were non-pelvic, so it would be things like diaphragmatic, umbilical, cesarean scar, anything outside of the pelvis. So then in terms of looking at association by kind of anatomic region, the ones that were significantly associated with appendiceal endometriosis were the ovary, uterus and fallopian tubes, and non-pelvic endometriosis. I was somewhat surprised that bowel was not statistically associated in this group. And then in terms of thinking about site number, we wanted to look at and see, does it matter if it's just in one site versus more sites, and how does that change the predicted probability of finding endometriosis in the appendix? So when there's 0 sites, we go back to that 6% chance. If we see nothing in people with, if we have no path confirmed endometriosis anywhere else, it's going to be 6% predicted probability. Then increases to 14% with 1 anatomic location, 36% with 2, 50% with 3, and 56% with 4 or more. Then in terms of complications, we didn't have any complications related to coincidental appendectomy during this study period or in the 12 weeks postoperative. In terms of strengths, this was a large cohort. It was a prospective database. We took a variety of different quality control measures to ensure our data was accurate. We had a lot of granular detail on operative and pathology findings. Some of the limitations, this was a single institution. Our pathologists there would section the whole appendix versus doing representative sections. There's some variability on that by institution. Because of the referral pattern and lack of synchronization of medical records, we weren't able to do any type of long-term follow-up or long-term quality of life outcomes. Because of surgical comfort, retrocecal appendixes were excluded. And then there's a lack of standardization in operative reports. So it was based on as much data as the surgeon gave. So then in terms of thinking about what do we do with this data and what's already known, essentially we can bucket it into 3 different options. So one would be to perform a universal coincidental appendectomy. Second would be to do targeted appendectomy based on operative findings. And the third would be targeted appendectomy based on appendix appearance. So in terms of kind of the pros for a universal appendectomy, we know that the baseline rate based on this data is 14.9%. The appendix was the only site of confirmed endometriosis in 5.5% of patients. We know abnormal appearing appendix. So in this group, 76% of our patients had a normal appearing appendix despite having pathology confirmed appendiceal endometriosis. It's safe, and we have other data that shows that it doesn't increase surgical risk or operative time. Cons, we don't know quality of life outcomes, and we don't have good cost effectiveness data. Kind of the middle of the road option would be doing targeted based on operative findings. We saw that there was clearly like a difference in terms of rate of appendiceal endometriosis, with people with stage 1 to 2 endometriosis having a 7% rate versus 35.2 with stage 3-4. So in this approach, you could choose to selectively do it for people with stage 3 to 4 endometriosis, endo on the ovary, uterus, outside of the pelvis. And then also for those with multiple different sites or compartments involved. And the final kind of most conservative option from a surgical standpoint would be saying, hey, we don't have quality of life data, we don't have cost effectiveness data, negative predictive value of 88% isn't terrible, I'll only take it out if it looks abnormal. I think the cons of this is we would have left a lot of abnormal appendixes and a lot of appendixes with endometriosis in situ. In this case, there would have been 67 of 91 patients. So in conclusion, appendiceal endometriosis is common in women receiving surgery for pelvic pain and especially endometriosis. Modern coincidental appendectomy is safe. So these are the references, and here's my contact info.
Thank you so much, Professor Ross. Like I said, I loved your paper, really. I was so looking forward to hear your presentation. And I think it's impressive. I don't know if everyone joined me with my same thoughts. And it's so common with stage 3 to 4 endometriosis. And like you said, like it's a fairly straightforward procedure when you don't have an infected appendix. So I wonder if you have like someone with severe endometriosis, if like you said, it's better to just perform an appendicectomy with everyone with stage 3 and 4, especially considering how low is the positive predictive value, like you said. I mean, 70, what do you say, 74, 76% of positive appendix look completely normal. What do the other people think?
I think, well, thank you very much. First of all, that was brilliant. I think first to go to where we are with LEJENDO, I love the format, even if I say so myself, that we get to hear this from the person who's done this for their research, and you know the data inside out. I'm really surprised by these findings. It's very interesting. So what really surprised me was that in a very significant number of normal looking appendixes, you found endometriosis. Now, of course, as you said it correctly, whether or not that has any clinical implication, or, you know, what does that mean, leaving an appendix behind that has endometriosis, and what's the incidence of any clinical problems in later life with that is one question. And although in your cohort there was no complications, we can't say there is no complication. So really the question is that rare complication that may occur as a result of appendicectomy, on balance with the rare clinical implication of leaving an abnormal appendix. I don't know. I think we should all go away and think about this. I think just talking about what my gut feeling is, of course, there's no question an abnormal looking appendix goes out. There's no question about that. So maybe now that I've seen your data, my threshold for calling an appendix abnormal looking may be lower. So maybe those cases where I looked at an appendix and I said, nah, maybe not, let's leave it behind. Now I will say maybe not, let's take it out. It would be interesting to see what others think, maybe from the audience or from the rest of the panel.
I'm curious, Professor Ross, now that with all your data, what does your unit practice? Do you do for everyone or all endometriosis patients?
Yeah, so my practice is to counsel everybody about it, and then do some patients, especially my patients who are nurses, are just like, please take it out no matter what. So use kind of a shared decision making. So there's some patients who have a strong priority, you know, it could cause issues. I have right lower quadrant pain, I want it out. But I would say in general, in terms of counseling, I would kind of, like you were saying, choose like the middle of the road option. If they have stage 3 or 4 endometriosis, there's some other papers that had showed a high association with deep infiltrating endometriosis. So I'll do kind of a selective approach, definitely if it's abnormal. And for people who have stage 3, 4, who have it in lots of different locations, who have deep infiltrating endo. I think the residents I work with kind of laugh. They're like, you're going to take any opportunity you can to take it. But I tend to leave it in people with mild disease, just because.
I think that's a good link to Marina's talk as well, because, you know, we are now talking about opportunistic salpingectomies for cancer risk reduction as well. And we did discuss this in our first LEJENDO, or the second one, that I think when we have a data like this, then the next question, which is almost impossible to answer, or at least it's not easy to answer, is how far do you take it? So when it comes to opportunistic salpingectomies, do we now say to general surgeons that, look, while you're there taking the gallbladder out, why don't you take the fallopian tube out as well in somebody? Or should we even say, look, let's just offer it to everyone? If it really reduces the risk of cancer by however many percent of cancer of ovary, maybe we should do this electively. And I'm not, by the way, I'm not suggesting we should. I'm just trying to demonstrate a point that then we can go to the extremes, and often the right answer will be somewhere in the middle. I don't know what you think, Marina.
Yeah, so indeed, it's important to balance the potential complications and the pros and cons. And definitely what I will be talking about with cancer risk is that we found in the literature that performing BSO, for example, so taking both ovaries and tubes out, is actually linked to significant long-term health risks. So it's really something that you want to consider, and we couldn't recommend to perform this in everyone. But for appendicectomy, I actually had a question. So is it linked to any long-term health complications or not at all? Is it really benign to you?
It seems to be very benign from what I found. Yeah, there's a high percentage of people that kind of live without it. There doesn't seem to be many consequences. I think the thought would be if there could be an impact on gut microbiome or health after a catastrophic infection. But there isn't good data in terms of how that affects individuals.
Mm-hmm.
Very interesting. So take-home message is actually the chances that you have endometriosis in the appendix is a lot more than what we thought, and I think your data is big enough to the other point you made was also very interesting about pathology and the way the pathologist looks at these, because I wonder how many of the normal appendices, if they've taken a lot more cuts, they will find something that they can call endometriosis. And for example, if it's only on the serosa and not, it's I don't know, but it's definitely food for thought. Very, very interesting.
Yeah, especially when it's located in more than 4 areas in the pelvis, is more than 50%. It's incredible.
Whitney, and one last question maybe from me. In terms of removing the appendix, I presume you guys do it yourself without the involvement of general surgeons, yes?
Yes.
Okay. Okay, good.
Okay, amazing.
Okay, shall we move on with the second part?
Yeah. Jamie, do you mind sharing the screen, please?
Who's going to start? It's going to be Avril this time. Far away, Avril.
All right, so this study I'm going to start off with is a study by a team in China, and their study was to compare the recurrence rate and the risk factors between patients who had treatment with for focal adenomyosis. And they divided patients into 3 groups. So one with surgery only, one with surgery and GnRH analogs, and then another one with surgery and the Mirena coil. And those with GnRH analogs, they were on it for at least 3 to 6 doses. So that would be about 18 months maximum. And then those with the Mirena coil, they need to be inserted within 3 months of the primary surgery. So next slide, please. Yes, so as you can see here, there was 75 in the surgery only group, 108 in the surgery and GnRH analogs, and 66 in the surgery and the LNG IUS. So they followed up these patients for a mean duration of 41 months. And what they found was in the first 2 years, there was no significant difference in the recurrence rate, but at the end of the 36 months follow-up, the relapse rate was significantly lower in the intervention group than the surgery only group. Next, please. And they also then looked at the other risk factors for recurrence. And as you can see here, there was a lower recurrence risk in those treated together with hormonal treatment. Interestingly, the recurrence rate was lower in those who had an anterior or a fundal adenomyoma, and also those with a longer menstrual cycle or a smaller diameter of lesion. They did further statistical analysis, and they found that the optimum cutoff points for predicting recurrence was 26 days for menstrual cycle lengths, 6 centimeters for diameter of lesions using the area. So in conclusion, what they found was a longer menstrual cycle of more than 26 days, a diameter of lesion of less than 6 centimeters, and a combination treatment using GnRH analogs or the Mirena coil were protective factors against relapse. And that's all from me.
Thank you so much, Avril. Yeah, very interesting. Like, it's always a dilemma how to treat an adenomyomas, isn't it? What do we have next, Jamie?
Yeah, just before Jamie starts, to say that we are now treating our first patient with high intensity focused ultrasound scan as of next week.
Fantastic.
So we're going to see how that goes.
Right, Jamie.
So, keeping on the radiological theme this week, this is actually a great fun paper to read. There's a few of them out there, but I thought this is one of the best written. And these papers have been around since about 2010. And it's basically what you should be doing at the moment with MRI. And so the paper is very, very well constructed. They refer to all the big papers, all the big names that have written on the disease, the pathophysiology. And it's pretty much understandable by anyone with a medical background. Explains why MRI is an excellent modality and compares itself to transvaginal ultrasound and laparoscopy. There's a shopping list of what's in and what's out, the do's and don'ts of imaging, and also explanations as to why T1 and T2 is not just that simple. There's some actually very complex medical stuff going on. You always have to go back to your anatomical landmarks, of course, the bits about thinking outside the box, and you'll see that, as I mentioned before, all the references are actually from high impact journals. So you've got to use a powerful enough machine between 1.5 Tesla and 3 Tesla. You can't use an open format machine, for example, it just doesn't give you enough fidelity. And you've got to slice in 3mm or smaller slices, depending on what you're doing. It says here, consider rectal cleansing and anti-peristaltic agents. I asked my local radiologist, and rectal cleansing is out up here. It may be a British thing, I don't know. And when you image the pelvis, you should do it regardless of the cycle. This next line about stir, I'll show you an actual picture of why. But they're saying maybe you should use contrast, especially post-infusion, and it certainly outlines dilatation of ureters. So if you have a look at these 4 pictures, there's lots of T2 and T1 and bits written underneath, but essentially the stir image is image C, which can't differentiate between an endometrioma and the surrounding tissues. Image A actually looks like a mature cystic teratoma, but the one that they've actually used in the end is called a Thrive sequence. And this is a super fast turn of electron phase array sequence. I couldn't say that more than once in a row. Shows you ultra white, ultra hot sequence there for an endometrioma. And that's why it's vitally important to get your right sequences going. Conversely, this was assumed to be an endometrioma, and it's only until you get to the very last picture, this has actually turned out to be a malignancy. So that one where it's very, very black on that background, this sense of vegetation. Like the IDEA study, there's good explanations of how the compartments are separated, and they want people to use a systematic approach, as we've discussed earlier in today's talk. And they're saying if you look at there's common things thinking outside the box. Your uterosacals, try oblique views if you can't see things straight away. Going back to your anatomy, there's a lot to be found from the fact that there might be neighboring structure deformation, which will give you a hint that things are going on. And if you use your contrast, again, this was the dilatation of ureters, you might be able to detect a nodule further down the ureter. Is there a pathogenomic findings to be found? So you've got the mushroom cap sign. I don't have a picture here. The teardrop sign, which is where you have this pulling of the bowel onto the back of the uterus. But also when you see hotspots on nerves and atrophy of muscles associated nearby, this can be directed to the surgeon. I was always amazed whenever we had MDTs that the radiologists would point to things, and when they show it to you, it's amazing. But this paper is a good adjunct to that. So overall, there's pages and pages of images. It emphasizes the need for expert training of the radiologist. So you need an interested radiologist. The way the disease changed, is it fibrous? Is it blood? Is it fatty? Will actually make sure the sequence is done properly. And then there is some radiology know-how, and that's that paper.
Thank you, Jamie. Yeah, it's going to be interesting. You mentioned malignancy. It's going to be very interesting, like to hear the second feature article with Marina Kvashkov. She's going to throw some light on this. Jamie, just a question, because I didn't manage to read this paper.
Yes.
Did you mention anything about thoracic endometriosis and diaphragmatic endometriosis? Say anything about MRI?
No. Yeah, this is one of the lacking parts of it. There's no mention of preoperative, a systematic preoperative setup like we've seen for the TVS. It was more actually what do the images mean and how are things done technically, but there was no mention of thoracic, no.
And what do you do in the States, Professor Ross? Do you use the MRI? Do you go for a CT scan? Do you do it when we're on their period for thoracic?
Usually for thoracic, we'll do CT scan, and then for pelvis, 3-2 MRI with an echo. Do
you wait for them to be on their periods or not?
Ideally, yes, but sometimes not. It doesn't always happen that way. And for some of my patients, they're already on suppression, so I wouldn't have to stop it.
Thank you. Okay, and our last paper is going to be presented by Avril, I think.
So my last paper is by Professor Engdin Oral and his team, recently published last year in JMIC. So they were doing a literature review looking at the comparison between isolated sciatic nerve endometriosis and sacral nerve root endometriosis. And the reason why they've said isolated sciatic nerve endometriosis here is they defined endo affecting the sciatic nerve, but this was not as part of a parametrial nodule. Next, please. So they had 40 studies involving 362 patients. The key findings were these type of endometriosis for both of them, they were more common on the right. Laparoscopic surgery was more commonly performed. Sacral nerve root was more often accompanied by deeply infiltrating endometriosis. Useful diagnostic tools for pre-op workup include MRI and myelography. And interestingly, in those cases with isolated sciatic nerve endometriosis presenting with foot drop, this did not show significant improvement after surgery. Next, please. So other important findings they had was for the patients with sacral nerve root endometriosis, endometriosis-related pain was more common. The finding of hydronephrosis was also more common, whereas for those with sciatic nerve root endometriosis, these patients reported sciatic pain and sitting pain, and there was a statistically significant difference. Next, please. In terms of examination findings for the sciatic nerve group, so I'm only discussing things that are significant in findings. So sciatic nerve group, they were more likely to report foot drop, leg motor weakness, whereas for the sacral nerve root group, they were more likely to report pudendal And looking at table 3 in terms of urinary symptoms, so urinary frequency and urgency, this was more common in the sacral nerve root group compared to the sciatic nerve root group. Next, please. And then in terms of surgical findings, surgical procedures, so as you can see in the sacral nerve root group, they were more likely to have surgery for deep infiltrating endometriosis, for example, segmental bowel resection, urethrolysis, adhesiolysis, and colpectomy. And interestingly, if you looked at the numbers for the segmental resection, no one in the sciatic nerve group had that. If you look similar with urethrolysis, 0, adhesiolysis, 0, and colpectomy also 0. Next, please. And I think that's all from me. Yes, thank you.
Thank you so much, Avril. Do you have any comment, Mikey, on this, or Mr. Ghazali? You are the expert about neuropelviology.
No, I think this is a very interesting one. I noticed that Professor Oral was on the call earlier. Maybe we should invite him and his team to present this as a featured article of the future ones. I don't see him now, but yeah, it's interesting. It's interesting. We need to remember another thing to say is that the little papers that they're not little papers, the papers that we are presenting in this fashion, we're not really appraising them properly. The idea is just to give a taster of what these papers are so that people can go and read. So this is just to introduce the paper, and a bit like, you know, the breakfast shows that they go through the papers of the day, the newspapers of the day, that this is in the news, but if you're interested, go and read them. Okay, and I'm noticing that, Ben, to your credit, you are running this in a timely manner, and there was a suggestion by some members of the team that maybe we should reduce the number of papers presented, and I think you have demonstrated that that's not necessary, and 6 works very well.
Yeah. Okay, so shall we go to our second guest? So thank you so much, Marina Kvashkov, for joining us. Marina Kvashkov works at the INSERM and the French National Institute of Health and Medical Research. And I'm really looking forward to hear your research as well, because she's gonna talk about endometriosis and cancer.
Yes, so just open my slides. Can you see my screen?
Perfect. Yes.
Yes. Okay, perfect. So thank you so much for the invitation. It's really nice to talk about this research. So this is the meta-analysis and a systematic review on the associations between endometriosis and cancer. And so the reason people have been interested in this is it's been observed that endometriosis shares similar features with cancer, such as abnormal tissue growth, development of local and distant foci, resistant to apoptosis, invasion of other tissues with damage to target organs, and fairly recently some deep endometriosis lesions were shown to have some known somatic cancer driver mutations. And so quite a few studies have looked into that. And so we did this search of the PubMed and Embase databases up to 2019. And we used standard methodology to perform this meta-analysis. And the thing that we did in particular is that we did subgroup analyses by the methodological characteristics of the studies in order to investigate the potential sources of study heterogeneity. So the search identified almost 18,000 records initially, and after the screening process, the analysis included 49 publications across 38 studies, so 19 case control and 19 cohort studies. And the first finding is that overall the quality of the evidence was rather poor, with above 50% of studies with serious or critical risk of bias. Nevertheless, so we observed a very small and non-significant association between endometriosis and overall cancer, 7%. And this was based on 5 studies. And here we can see that there was substantial heterogeneity in the findings. And so basically, heterogeneity is measured through the I-square statistics, which reflects the inconsistencies across studies. It's the percentage of variation across the studies that is due to heterogeneity rather than chance. And so with an I-square of 88%, we're at the level of substantial to considerable heterogeneity. So to dig deeper in the associations between endometriosis and cancer, we then looked at associations with different types and sites of cancer. And ovarian cancer is definitely this cancer site that has been the most studied in relation to endometriosis. And so here, based on 24 studies, we found a summary relative risk of 1.93. So this confirms a positive association with a close to doubling risk of ovarian cancer among women with endometriosis. However, as you can see, there was a high level of heterogeneity here. And when we looked into publication bias, we can see that in this final plot, which is supposed to be symmetrical, a lot of the studies are directed towards the right here. So this means that positive and statistically significant results were more likely to be published and are biasing the results towards an overestimation of the true relationship between endometriosis and ovarian cancer. And so here I'll try to go quickly, but this was really the added value of this meta-analysis. It was to look at the different study types and methodological characteristics. But basically what we found here is that the association was lower, was weaker in those designs that were deemed less robust methodologically. So the association was actually more robust in cohort studies, and in particular prospective cohort studies. And it was also higher in those studies that took into account the temporal relationship. So making sure that endometriosis actually occurred before the ovarian cancer. And then looking at self-report versus clinical records, here again, the association was stronger when the diagnosis was based on clinical records. And so this is a hint of a true association because when we see more robust designs, the association is strengthened. So we dig deeper into the heterogeneity by looking at different associations by ovarian cancer histotype. And so here we found that there was a significantly higher association with the clear cell endometrioid subtypes. And there was also a small association with serous tumors. And for serous tumors in particular, it was stronger among the low-grade serous ovarian cancer. When we looked at studies that did provide findings according to the macrophenotype of endometriosis, so first there was very few studies that looked into that. There was actually only one study that looked at superficial deep endometriosis and endometrioma, but there were 4 studies that looked into the association with endometrioma. And there was a small and non-significant association with superficial endometriosis here, no association with deep endometriosis, but there was a very strong association with endometrioma here, based on 4 studies. But we argue that these results should be interpreted cautiously because first, there was a very high level of heterogeneity here again, with a high level of imprecision, because we can see that the confidence interval is very wide. Also, a couple of the studies were performed in selected populations. None of the studies considered endometrioma exclusively. So this is endometrioma maybe alone, maybe with some other types that can differ. And importantly, the diagnosis is more straightforward for endometrioma. So there may be detection bias and diagnostic bias because, you know, we can't know for sure that these women had didn't have any other types of endometriosis. So I've presented this already, but so basically there was this study that looked at the different types of endometriosis, and it looked at the 2x2 heterogeneity because it looked at different types of endometriosis in relation to different types of ovarian cancer. And it showed that endometrioma was associated with the clear cell endometrioid and serous subtypes, just like the overall association. whereas the superficial peritoneal endometriosis subtype was mostly associated with the endometrioid and clear cell ovarian cancers, and deep endometriosis was not associated with ovarian cancer risk. So quickly now, just to show you some findings with other cancer types. So there was very small association with breast cancer. It was only 4%, and it was borderline significant. And this was based on 20 studies. And based on 17 studies, there was a 23% high risk of endometrial cancer associated with endometriosis that was close to statistical significance. But actually, there was a high heterogeneity here. And if we dig deeper into that, looking at case control and cohort studies, we no longer find a significant association. But if we look at cohort studies in particular, and we looked at the retrospective cohort studies that are the ones that do not take into account the temporal relationships between endometriosis and endometrial cancer, we see that there was a positive association with, again, a high level of heterogeneity. Whereas among prospective cohort studies, there was actually a very null association with here actually no heterogeneity at all. And so this shows that we really need to look at the studies that are well designed to explore associations between endometriosis and cancer, because if the methodology isn't robust, we can actually get wrong answers, and even with a meta-analysis. So basically, the association with endometriosis and endometrial cancer is mostly a co-occurrence one and not a temporal relationship. For cervical cancer, there was actually an inverse association with endometriosis, and we think that this is unlikely to reflect causality, but rather an early detection bias, because endometriosis patients go more frequently to the gynecologists and maybe get diagnosed earlier for cervical cancer, or actually cervical hyperplasia. For melanoma, there was a 17% high risk that was non-significant. And here, actually, when we look at the more robust studies, it was the opposite as for endometrial cancer, because those studies that were robust actually show a strengthened relationship, whereas the other ones show null association. For thyroid cancer, there was a 39% high risk among women with endometriosis, with no heterogeneity, whereas there was no association with colorectal cancer. So in sum, there was a high risk of ovarian cancer, breast cancer, and thyroid cancer in this meta-analysis in the association with endometriosis. There was also a low risk of cervical cancer, but there was no association with colorectal cancer. And we consider that the evidence is unclear with endometrial cancer and cutaneous melanoma. So, and there was also a positive association between endometrioma and ovarian cancer, but the evidence is uncertain and needs more research. So overall, there is insufficient evidence, and we need more carefully conducted research to have a clear and complete picture of the link between endometriosis and cancer, and particularly with regards to disease heterogeneity. So I don't know how we are with time now, but probably it's it's probably I won't have time to develop this. I will just pass through, but basically there's a lot of methodological complexities that need to be taken into account in these analyses, because study designs that fail to take methodological considerations into account may actually provide the wrong answer, and we've seen that with the endometrial cancer association. And just very quickly to talk to you about informing patients, because these studies being in the literature means that patients have access to information and hear that endometriosis may increase the risk of cancer, and that might actually be very worrying for them and for clinicians. So in 2017, we published a letter about this. And at the time, there was a meta-analysis for the association between endometriosis and ovarian cancer that led to a 1.42 relative risk for this association. And when we translate this in terms of absolute risk, this translates into an absolute risk of 1.3% of ovarian cancer in the general female population. Whereas in women with endometriosis, so it's higher, but it's 1.8%. So it's not so big, it's still very small. And if we update this with these new meta-analytic results of 1.93, this goes up to 2.5%. So basically, the risk of ovarian cancer is double among women with endometriosis, but nevertheless, it remains really small. So patients can be really reassured about their cancer risk because 97.5% of them will not get ovarian cancer, which is a much more important number to remember. And in this letter, which I encourage you to read, we have provided some key messages for clinicians in order to aid in addressing the concerns of the patients about the potential ovarian cancer risk. And here in the ESHRE guideline on the management of endometriosis, there was an endometriosis and cancer chapter in which you will find this infographics here, where we show with a visual that the difference between basically all women here, this is the absolute risk of cancer in a general female population. And we see that the difference with the bottom columns here is actually very small. And so that's it. So the take-home message is that the current epidemiological evidence for a link between endometriosis and cancer is mostly not reliable due to the low methodological quality of most studies in the field. And further research needs to take into account some critical methodological issues in order to produce summarized answers. And most of all, future studies needs to explore heterogeneity, both by endometriosis and by cancer type. And I'd like to acknowledge my co-authors, and I thank you very much for your attention.
Thank you so much, Marina, for this presentation. It was great, really.
I'm sorry, I went a bit over.
No, it's perfect. It's perfect. It was really a nice presentation.
I have a question. Was there any papers that looked at the association between like severity of endometriosis and like the different stages and cancer, or was it just endometriosis only, or like peritoneal ovarian endometriosis?
That's a good question. I don't remember having seen that. I don't know if you do, Shaheen, but
no, I think when we were working on the ESHRE chapter, although I say we were, you did most of the work. We sort of did only a little. We did go through all of these papers, and it was surprising that some of these studies didn't even differentiate between endometriomas or no endometriomas, let alone going into more details. And of course, as you all know, and you know, this is my hobby horse as well, staging of endometriosis is a complete nonsensical situation, or has been. It's improving. But no, I don't think we know much, but it makes sense that endometriomas would be where we should be looking, really. And that's what the low quality evidence is supporting. The one comment I had, Marina, was that you're absolutely correct in raising the issue of how this data can be misunderstood and how this can cause panic and how it can cause, and I've already seen that in my patients who come and say, okay, I have an endometrioma, I have no symptoms, but take it out because I can get cancer. And the reality is you need to give them the data. You need to say that, yes, of course, there is an increase. We think there is an increased risk of cancer, but that risk is small. And if you balance that against the risk that I will be causing by removing that ovary, be it the intraoperative risks or the long-term risks of losing an ovary or losing some hormones, maybe the effect will not be as much. But the reality is it will be for the patient to decide. We need to present the data in an accurate and responsible way. And I really think that having access to resources like the pictogram that you just showed is going to be very helpful, because if we don't do that, each of us is going to use one kind of language or terminology, and then that may cause a problem.
Absolutely. Does anyone have any questions about the presentations that we had today from the delegates? Seems no questions.
No questions at the moment.
No.
Nope.
So everybody has been very clear then.
We have one. Let me read it 1 second because it's a long question.
And this is from Amina Hagu.
Yeah.
So maybe we'll read it out loud. So as you mentioned, there was no relation between deep endometriosis and ovarian cancer, but there is an association with the superficial endometriosis. So as pure deep endometriosis is not always seen, and many of deep endometriosis lesions are seen with superficial endo too, how there is no association between deep endo and ovarian cancer, but with superficial there is. So that's a good question. I think it's been a bit messy in the studies, because none of the studies, even in the really nice study, looked at the subtypes of endometriosis exclusively, and it's very hard because we don't know the combination of the other subtypes of endometriosis in those participants in those studies. So we need to document all of this to really know, because women with, you are right that women with deep endometriosis lesions may have superficial endo too, and so we just don't know in how in what proportions. So we need studies that document things in a standardized way a lot more. That's for sure.
And Olivia is asking, for the association between endometriosis and cancer, did you observe any confounding factors like the race, lifestyle, BMI?
That's a good question. So no, we didn't find any studies looking at that actually, but there is a very recent study looking at this, and I just don't remember its findings, but it's been presented recently at the World Congress on Endometriosis, and it's just very recently being published. So it's a study by my colleague Holly Harris from the Fred Hutchinson Cancer Center, and in the ovarian cancer in women of African ancestry consortium, she looked at the association with endometriosis and ovarian cancer, and she looked at racial differences. And she showed that, she says that Black and white participants with endometriosis had a higher risk of ovarian cancer, and hysterectomy modified the association among white participants. So I haven't read the study in detail yet because it's just been published. But basically, no, I don't see the numbers from the abstract.
I think
that would be really interesting.
Yeah, it's going to be a good study that we can probably bring up in the next sections of Legendo.
Exactly.
So that's up, really.
Exactly.
So I think is 7:15 and probably wrap it up. Thank you so much to Marina Kovacsov and also Whitney Ross for joining us today. Thank you to the Legendo team, and thank you as well for Karl Storz that is supporting us from the technical part of Legendo. And we hope to see you next month, the 6th of July at 6 p.m. Thank you, everyone.
Thank you.
Thank you, everybody.
Thank
Thank you.
you.
Thank
Cheers,
you.
everyone.